So I am a consultant gynecologist and endometriosis surgeon. I was working in Manchester just a little bit, but I am kind of in a life-changing situation. But me and Manchester are always like heart to heart. So that's what's going on. And thank you so much to Endometriosis UK for organizing this. This is a great opportunity for me to present what I know and also to learn from the audience as well. I have been looking at some of the questions that were coming in for the webinar, and I really did have to hit the books again. So that was fantastic stuff. So I don't know if many of us have, I was unfortunate enough to watch this movie in the cinema. So it was absolute garbage. It was Godzilla versus Kong, and there was certainly a bit between Godzilla and Kong, which made me actually think whilst I was sitting in the cinema about fibroids and endometriosis. So that's why this photo just had to be there. So what I feel that endometriosis and fibroids are, I do feel that they are the two big monsters of the pelvis. And really, my reference to the monsters is going to come a few times during this presentation, just because I think there are many things that we can do to alleviate the symptoms, and there's many things that you can do to actually get rid of the monsters as well. And that's a few of the things that I'll be discussing today. And so it goes back to the age-old question about the symptoms. And funnily enough, there is quite a lot of congruence between endometriosis and fibroids and the symptoms between them. As you can see, you can't really tell the difference between them very easily. Endometriosis is a full body disease. You know, it's like constantly draining on your body and constantly giving you fatigue and malaise. And with fibroids, one of the major symptoms of fibroids is heavy menstrual bleeding, and that can lead to fatigue due to anemia. You can also get frequent urination in endometriosis, particularly if you have endometriosis around the bowels. And the pain during urination is also part of endometriosis. And the pelvic pain and cramping is there for both, and subfertility is there for both. Ovarian cysts is there, mostly for endometriosis, not really related to fibroids, but abdominal bloating and protruding abdomen is there for both as well. So it's very difficult for someone to tell the difference between the two. And without specialist input, it can be very challenging to diagnose, let alone manage. And it can leave a patient in significant dilemma and significant problems with their quality of life, because it can prolong the time from presentation to the time that it's properly diagnosed and managed. And so, coming back to the monster analogy, what do all monsters need? Monsters need food. And the bag of Monster Munch is there because this bag of Monster Munch is completely full of estrogen. And so that's how I like to describe what happens with endometriosis and fibroids and how they grow and get stronger. They get stronger with estrogen. Just going back to what estrogen actually does, and thanks for these graphics that I found online. Estrogen, it maintains skin moisture, elasticity, protection of the bones and the heart, and regulates cholesterol levels and regulates the mood. However, also on the other side, it regulates the menstrual cycle. It helps with the development of secondary sexual characteristics, helps to grow the lining of the womb, and maintains the lining of the vagina and the vulva. And coming back to it, it does feed the two monsters. Estrogen, these are both estrogen dependent in many ways. And so Endometriosis, classically, and endometriosis is an estrogen-dependent disease. Estrogen helps grow endometriosis patches throughout the abdomen, throughout the body, and same thing goes with fibroids as well. With fibroids, estrogen can help the growth of fibroids, and that's why some of the therapies to reduce the size or actually tame the size of a fibroid can be targeted towards reducing the amount of estrogen. So there are some gynecologists that say things will get better after the menopause, but that is not the right strategy to have when you're trying to aim to reduce the symptoms from these conditions, and particularly when they happen together. So estrogen does decline with age. However, this is not the right attitude to have if you're a healthcare professional when someone comes in through your door asking for help. So what can you do to stop the monster? Go back to it, the monster loves estrogen, so can you do things to reduce estrogen? Look, all these things are used to reduce symptoms and also manage symptomology, but it is certainly not the cure of the disease. So there are two ways you can do this, mainly in contemporary gynecology, that is GnRH agonists and GnRH antagonists. There are many other ways of reducing estrogen in the body. Anything you do to reduce estrogen will starve both endometriosis and fibroids. So GnRH agonists classically are the injections that you've heard of, such as Prostat, such as Lupron, such as we've got Zolidess. And there is one thing though, because they're agonists, it actually is the chronic administration or larger dose administration of these medication that leads to the suppression of LH production, which in turn reduces the levels of estrogen. So it can actually take some time from the time you get the injection to the time it starts to work. And then after it started to work, it can take some time to leave your system, you see. So it has a slower mode of onset, and also it can take some time to leave your system. Whereas GnRH antagonists, and this is something that is absolutely brand new to the UK market, they block the GnRH receptors directly, which leads to immediate LH suppression and immediate estrogen decline. So they have a faster mode of action, and then they also can, upon withdrawal of the medication, completely leave your system. In that, there is a medication in the market called Rico, and Rico is a 1 per day oral drug for adults with moderate to severe symptoms of uterine fibroids, and has been given the green light by NICE in October 2022. And Rico is not only a GnRH antagonist, it is also got a little bit of estrogen and a little bit of progesterone, just to keep your menopausal side effects that comes from anti-estrogen therapy at bay. So you don't need to take extra HRT from it. It's certainly catching a lot of attention in media, and I think you will see your gynecologist recommend it to you very soon. And we all know the symptoms of estrogen imbalance or too little estrogen. Too little estrogen can lead to infrequent periods or no periods, lack thereof fertility, and lower bone density, vaginal dryness, hot flushes, dry skin. But as I said, Rico has a little bit of estrogen and progesterone, so these symptoms are at a much lower level or not at all. And some of these symptoms can be locally managed. But again, this is just a way of managing the symptoms. So can we do damage control? Damage control meaning, you know, if the monster's already created havoc and the buildings are all destroyed, now you got to make them up or do something about your city. Yeah, you could, you know, primarily this involves heavy menstrual bleeding and the management of heavy menstrual bleeding, particularly with fibroids. Endometriosis can be invariably related with adenomyosis in some studies up to 80%. And so that can lead to heavy, painful periods in endometriosis, whereas in fibroids, you can get heavy menstrual bleeding in a lot of the cases, in most of the cases. And so ever since 2015, endometrial ablation has caught the eye of the media as well, calling it a magic wand that reduces the misery of heavy periods. More recently, there are more handheld outpatient devices that actually can do this in an outpatient setting, namely ones which have balloons that heat the inside of the uterine cavity. There are ones that have little wires that can actually do a microwave ablation of the inside of the uterine cavity. And there's the classic thermal ablation, which you have probably seen, the radio frequency thermal ablation, which you've probably seen in your gynecologist's office. That is, it looks like a fan that fills up the uterus. So can surgery be an answer? Now, in endometriosis and fibroids, surgery can be incredibly complex. And for the sufferers of endometriosis, and particularly if it is higher grade endometriosis, you know that this conversation has been a part of your discussion with your gynecologist, that, you know, your surgery can be incredibly complex, particularly if the endometriosis has spread to extra pelvic organs such as the bowel, the bladder, or also the diaphragm, or other organs where it's not supposed to be. So that can lead to surgical complexity. But coming to the theme of this webinar, all of these things can actually occur together, which can make a big mess in the pelvis, which honestly requires a great deal of complex gynecological surgery to solve and resolve the anatomy. Therefore, coming back to fibroids themselves, fibroids and adhesions can happen concomitantly in 80% of cases. That's because fibroids have a way of increasing blood supply and increasing the growth of blood vessels in the pelvis, and that in itself can lead to stickiness inside the pelvis, causing adhesions or scarring. Fibroids and endometriosis can occur together in about 50% of cases, and again, when both of them happen together, most of the time endometriosis has extra pelvic spread about 33 to 40% of the time, and that can lead to severe complications and require really complex surgery. And as you know, fibroids can occur alone in about 25% of the cases when there are adhesions or endometriosis available. So it's not just surgery that that you should be thinking that you should think it is. You know, it's when your gynecologist thinks that you have come to the point of surgery, it's not just surgery. The current surgical planning technique is, and there is an MRI scan, and after the MRI scan, your surgery is done. And you know, that needs to change. That needs significant change so that you can have proper surgery done the first time and with the best outcome. And also, there's a lot of the audience who would have been sold the two-step procedure, which is you get the procedure done in 2 steps. Either do the fibroids first, and then after a few months we'll do the endometriosis, or do the endometriosis first, and after a few months we'll do the fibroids, or do neither first and do IVF first and hope for the best. So these things require excellent multidisciplinary team planning, and it's not just a simple operation. There is a video I'd like to show you all, and that video is all about a laparoscopic myomectomy and how simple the procedure can actually be. And so the fibroids classically are said that they grow in the muscle of the womb, but they can grow in the surface of the womb, or even in the lining of the womb as well, which can have different ways of dealing with the fibroid. It's very important to do pre-surgical planning and optimize a patient's hemoglobin, because more often than not, people who have fibroids will lose a significant amount of blood during their periods, and may have a very low HB before any surgery is planned. And before the surgery, you should also consider if you want to plan a reduction in the size of the fibroid, particularly if the fibroid is well over 14, 15, 16 centimeters. And that can be done with medication. It can be done with GnRH agonists. It can be done with GnRH antagonists. It can also be done with uterine artery embolization. And so the procedure is as follows. You make a cut in the surface of the womb until you know where the capsule of the fibroid is. And one of the things I like to do intraoperatively is inject a special medication in the lining, in the muscle of the womb, that reduces the blood loss, because this area is exceptionally rich of blood supply. So those injections just work temporarily to reduce the blood loss whilst you're doing the surgery. And once you've made the incision, you can actually see the white fibroid on the inside of the uterus. And then you pull the fibroid out. And after the capsule is left, you stitch the capsule up, and you stitch the top of the fibroid up. I mean, the top of the womb up, sorry. And that's generally how easy a laparoscopic myomectomy can be. But now imagine the exact same situation with a lot of adhesions, a lot of stickiness 80% of the time. And when there's endometriosis happening up to 50% of the time, it can actually lead to endometriomas. It can lead to bowel endometriosis stuck onto the fibroid, or bladder endometriosis stuck onto the fibroid or the uterus from above. So this can require a great deal of planning. So it's not just simple surgery, as simple as I just showed you. It is complex surgery. So you remember that the surgical planning that currently happens goes from MRI to actual surgical procedure. But what you should be doing is good, complex surgical planning, so that you can give the best surgical outcome for every patient that you treat, particularly in patients who have more than one morbidity. So more than one thing going on at the same time, such as fibroids and endometriosis, fibroids and adhesions, or fibroids and all three of these things. And so things such as, after you do an MRI scan, you could get your radiology team to create a 3D model of the organ in question, that is the uterus, and also the pelvis. You basically then can have a multidisciplinary team meeting and discuss the variations of what you could surgically do and in what order. And once you've got a satisfaction, you're satisfied with the order in which you'd like to surgically carry out the procedure, you decide on it as a team, and then make sure that the most senior person is doing such surgery. I've already mentioned pre-surgical optimization, and these things include things such as improving a patient's hemoglobin, and intraoperative considerations, that is using things such as vasopressin, so that you can reduce the blood loss during the surgery, and also planning for extra blood loss, so you get blood ready, and so that the blood's there ready for any eventuality, and also you could consider things such as cell salvage, so that you're giving the patient's own blood back to them if there is extra blood loss. But in my experience, in the last 30 myomectomies I've done, using vasopressin, we don't get enough blood loss to give a transfusion at all. And then there's the post-surgical planning. Some of these patients would require going to required to go to ICU afterwards, and so that's something that you need to consider and plan with your anesthetic team as well. And all of these things happen at the MRI stage. I wanted to share with all of you, not real surgical videos, because it can get quite squeamish. I would like to share with you, however, a couple of MRI scans. And this is an MRI scan of a poor lady who had both endometriosis and fibroids, and adenomyosis, and bilateral endometriomas. And as you can see, these things require really complex surgical planning to decide in what steps you'd like to do the surgery, and also who would be involved. Would you need a bowel surgeon there to protect the bowel and do some bowel surgery? Would you need a urology surgeon there to protect the ureters? And sometimes complex surgical planning also requires good understanding of what an MRI scan is. Although on an MRI scan, to most people, this could look like a fibroid uterus. It is in fact an adenomyoma. So adenomyomas, if they are chronic adenomyomas, sometimes they can resemble a fibroid even surgically. So it can look very hard and very thick. But in fact, what actually it is, it's adenomyosis within the uterus, which requires a degree of complexity and a degree of seniority to actually deal with laparoscopically. So in this case, this is an adenomyoma and not actually a fibroid. However, this also is part of a patient who had quite significant endometriosis. There are newer answers though, so sometimes two-stage surgery does not really mean that you're doing two-stage surgery whilst for the patient whilst the patient is asleep. You could actually do two-stage surgery for certain cases where the first stage is in the outpatients and the second stage is an inpatient procedure where the patient has had to be put to sleep. These include things such as the Sonata treatment. The Sonata uses a handpiece with a miniature high-resolution ultrasound tip that allows the doctors to see the fibroid from inside the uterus during the procedure, and then treat each fibroid with a process called radiofrequency ablation. So basically what happens is that the ultrasound scan actually scans to see where the fibroid is, and the handpiece also has a handpiece that delivers radiofrequency energy to shrink the fibroid over time and reduce the symptoms. And our unit is one of the first units to do the largest number of radiofrequency Sonata treatments in the country. So Manchester and my colleague Dr. Gail Busby is leading that in the country. So I think that is also an option for you before you go for any surgery. And also, if you think about it, if the fibroids are small and they're more towards the inside of the uterus, Maybe the answer is getting a hysteroscopic myomectomy, which is when a camera goes inside the womb and actually takes the scope goes inside the womb and takes the fibroids away. So that with the second surgery, if you have larger fibroids or significant endometriosis on the inside of the pelvis, you can deal with it, knowing full well that you've done a great job hysteroscopically. Or you could do both of those things, the hysteroscopic myomectomy and the laparoscopic myomectomy plus minus an excision of endometriosis whilst the patient is asleep in one go. I've always been a fan of one go, as long as you do great surgical planning. So lastly, my final word is that it's not simple. Today I have covered as many of the new ways of dealing with endometriosis and fibroids, and endometriosis or fibroids together or apart as I could, because we all know all the age-old tricks that gynecologists and GPs have used to make sure that you have your symptoms at bay, but then they keep coming back because they're not dealing with the actual problem. So it's not simple. I would do the following as a patient. Expect an MRI scan in the presence of extra pelvic symptoms, which means if you have bowel symptoms, if you have bladder symptoms, you should full well expect an MRI scan. If you're being strung along with a series of ultrasound scans, and if you're being strung along with no imaging at all, I really do think that you should be reconsidering who is your healthcare provider, or maybe look for a second opinion, basically. Secondly, insist on a consultation with an advanced laparoscopic endometriosis surgeon who will listen and address your concerns comprehensively, because that's what we are trained to do. We are not just trained to be surgeons, we are trained to be specialists in complex benign gynae work, and we are trained to listen and actually look for the little things that you would complain of that will make us think, you know what, that tells me that the anatomy has shifted. Thirdly, accept a multidisciplinary team review of your case before any surgery is planned. That is absolutely paramount. I think if you have any two conditions, let alone endometriosis and fibroids together, if you have endometriosis and anything else together, or if you have fibroids and anything else together, you should really ask your gynecologist or healthcare provider if he thinks you should have an MDT review, because currently the excellent system within the United Kingdom of endometriosis centers means that a multidisciplinary team review is only a request away. And my last point is anatomy shifts at a glacial pace when you have such conditions, but it does shift. So in my experience, I have seen and I have experienced anatomy change in the same patient whilst a patient's been waiting, and more often than not, pathology gets worse. So fibroids will get bigger if they're not dealt with. Endometriosis, I believe, progresses if it's not dealt with. The longer the wait for surgery, the worse the anatomy can get, and may get, but more often not does get. And the more complex a case can become surgically, I recommend a repeat MRI scan if you have been waiting for more than a year for your surgery. So that's if you've been selected to have an MRI scan in the first place, you should really be having a repeat one. And then there's the point of what can you do if you need answers, what help is out there, and you're stuck in a place where you can't really get answers. I really think that I really think that there are many novel ways of answers out there. There are toolkits that you can find on the Endometriosis UK website. There are toolkits that you can find on a lot of the endometriosis forums online. And if you answer those toolkits, you might be able to tell whether or not your symptoms are more inclined towards endometriosis or not. Particularly if you have been told that you have got fibroids, your symptoms are due to fibroids, and then eventually you are starting to get different symptoms and no one's really thought endometriosis. That could be a big problem, because that will prolong that period again. That will put you as one of the many patients that's been waiting for 8 years for a diagnosis of endometriosis, even though you have fibroids, or a diagnosis of fibroids, even though you have endometriosis. So if you need answers, those toolkits are out there. One of the things that I would also like to point towards is artificial intelligence. So artificial intelligence could have the answer. So there is a great tool online called EndAI.co.uk. You could basically just speak to Anna, and Anna will tell you whether she thinks you've got, whether she thinks you've got adhesions, whether she thinks you've got endometriosis, whether she thinks you've got less endometriosis, complex endometriosis, and she can also tell you whether she thinks you've got, whether she thinks that you need an MRI scan. So it can actually help to speak to artificial intelligence nowadays, and it's all the rage right now on every single social media platform. So this is yet another tool. So thank you, everyone, and thank you, everyone, for inviting me and patiently waiting for me to ramble on about endometriosis and fibroids, because this is what I'm passionate about. And I'm sure there are thousands of questions to answer. But please, like anyone else in the world right now, I have embarrassingly taken to TikTok as well. So if you can join me, that's great. I'll be even more embarrassed for plugging myself today. So I'll give it back to Emma, if that's okay. And I think we've got loads of questions.
Yes. Thank you so much, Zahid, for your talk. And we do have loads of questions. I'm going to start with the first one. So, is there a connection between the growth of fibroids and the combined pill? If so, what advice is there for those who have to take the pill to manage endometriosis, but also have a history of fibroids?
Of course. So there's limited evidence to suggest that the use of the combined oral contraceptive pills, or commonly known as the pill, may be associated with a slight increased risk of developing uterine fibroids. However, the evidence is not conclusive, and more research is needed to fully understand the relationship between combined oral contraceptives and fibroids. If you have a history of fibroids and also need to take the pill to manage endometriosis, it is important to discuss your options with your gynecologist. Depending on the severity of your symptoms, your gynecologist may recommend a different form of hormonal management, or suggest monitoring your fibroids more closely whilst you're on the pill. In some cases, your gynecologist may also recommend surgical intervention to remove the fibroids, especially if they're causing significant symptoms or interfering with your quality of life. It is important to work together with your healthcare provider to develop a comprehensive treatment plan. Yet again, a plan that is strategically taking into account your medical history and individual needs.
Thank you, Zahid. My next question is, who's part of the MDT?
As MDTs are evolving, these can get quite large. However, the basic MDT that is recommended by the British Society for Gynecological Endoscopists, the BSGE, is the gynecologist who is trained in advanced laparoscopic surgery. So the advanced laparoscopic surgeon, a colorectal surgeon, urologist, so a colorectal surgeon in case there is bowel surgery required, a urologist in case there is protection of the ureters required, and also an endometriosis nurse and a data manager that helps deal with the data that comes in from such surgeries. So those are the four main components of an endometriosis team, and adding to all of this is also the anesthetist who does the pain management plan for the patient whilst all of this is going on.
Okay. And when will we see better and less invasive treatments for endometriosis and fibroid sufferers? It feels that not much is changing in terms of the management and we're still suffering.
I think endometriosis and fibroids are complex conditions, and whilst there's been progress in the development of the treatments, there's still much work to be done. There is ongoing research efforts to develop further and less invasive treatments for both endometriosis and fibroids. And some of the promising areas of research include non-invasive techniques, where researchers are exploring the use of non-invasive imaging techniques such as MRI to better diagnose and monitor endometriosis and fibroids. This could help reduce the need for invasive procedures like surgery. Targeted drug therapies, scientists are studying new drugs that can target specific molecular pathways involved in endometriosis and fibroids, and these drugs can potentially provide more effective treatment with fewer side effects than current treatments. And minimally invasive surgical techniques, as I have mentioned, surgeons are developing and refining minimally invasive surgical techniques to remove fibroids and endometriosis tissues. And these techniques can reduce recovery time and minimize scarring compared to open surgery. Whilst progress is being made in these areas, it can take time for new treatments to be developed and brought to the market. So in the meantime, it is important to work with your gynecologist to find the best treatment plan for your individual needs.
Thank you. And so how would you treat someone with endometriosis, fibroids, adenomyosis, with anxiety and depression, who does not want anything to affect mood and mental well-being?
This is it sounds like a very complex and uncommon situation, but unfortunately this is a very, very common situation. As I have mentioned before, it is incredibly important to provide a multidisciplinary plan for these patients. You cannot be a one-man show. You cannot be a cowboy and try and do everything yourself. You see, there are specialists, there are mental health specialist nurses. As I said, the core MDT may include those 4 + 1, 5 people, but the MDT, the idea of a multidisciplinary team is expanding. Certainly in Manchester, we have a specialist endometriosis pain clinic, which is currently carried out by my colleague, Mr. El Sherbini, and he carries it out with an anesthetic colleague, and we also have a direct relationship with the psychology services and the clinical psychologists. So this can bring a whole host of solutions to such a complex situation, you see. So I do feel that in the modern definition of the term, there is a bit of injustice that happens to endometriosis surgeons, that all we think is cut. But to be quite honest, endometriosis wise, I think we have been trained to think holistically, and and we have been trained to give treatment plans holistically as well. So it's incredibly important to think of the situation holistically. So unfortunately, there's no one answer to this, but the answer is a multidisciplinary plan be made, particularly with a clinical psychologist input. Everything else can be a complex negotiation between you and your gynecologist, depending on where in the country you are.
Thank you, Zahid. And my next question is, so why is there a delay in diagnosis of endometriosis in 2023? Should there be a reform in NHS training and further education to avoid misdiagnosis misdiagnosing and early detection?
Uh, I think the delay in the diagnosis of endometriosis is a complex issue that is influenced by a variety of factors. One of the primary reasons for the delay in diagnosis is the fact that endometriosis is often mistaken for other conditions that include that cause similar symptoms, such as IBS or pelvic inflammatory disease. Additionally, there is a lack of awareness and understanding of endometriosis amongst healthcare providers, which can lead to a delay in diagnosis. Improving education and training for healthcare providers is one way to address this issue by increasing awareness of the symptoms and the diagnostic criteria for endometriosis, particularly the work that's being done by Endometriosis UK. Healthcare providers can also more accurately diagnose the condition and provide appropriate treatment. This would involve incorporating more information on endometriosis and other women's health issues into medical school curriculums and continuing education programs for healthcare professionals. In addition to training healthcare providers, it is also important to raise awareness amongst the general public, which again, the Endometriosis UK is doing so well. Certainly, I've been in many different parts of the world. I am currently going to many different parts of the world to see how endometriosis is affecting people across the globe. And the general public does not know about endometriosis. I went to the Philippines and no one knows about endometriosis there. You see, we are so lucky in the UK to have such an active charity that works for this very purpose. And this could involve public health campaigns or community outreach programs that aim to educate women about endometriosis and encourage them to speak to medical professionals if they experience any symptoms. Finally, improving access to diagnostic tools and specialist care, which can help reduce the delay in the diagnosis for endometriosis. This could involve increasing funding for research and diagnostic tools, as well as ensuring that women have access to specialists in women's health who are knowledgeable about endometriosis. That is the endometriosis specialist. Overall, a comprehensive approach that involves improving education and training for healthcare providers, raising public awareness, and improving access to diagnostic tools and specialist care is necessary to reduce the delay in the diagnosis of endometriosis. And also, I am the ever technophile, so I live around computers, and I really do think artificial intelligence as well. So, you know, that's why I mentioned Anna.
Thank you, Zahid. And so if someone's had fibroids removed, will they come back and can they become cancerous?
So this is a very difficult question to answer because it all depends on a variety of factors and a variety of imaging results, you see. So if you remove fibroids and if you remove them well, the chances of them coming back is less than 5 to 8%. Yes, particularly if you have had a good clearance. However, I've probably in my experience seen that number. I've seen 5 to 8%. I don't think I've seen more than that. Secondly, I have never seen a uterine sarcoma or come across a uterine sarcoma in my life. I have heard of it in a center far, far away, you know, like an urban legend, but I have never actually seen one. I've never come across one. However, the most important thing in this whole situation is, number one, if fibroids come back a little bit too fast, make sure you look at that MRI twice and make sure you think about whether or not you want to get a CT scan because it could be sarcoma. If a fibroid grows too fast, again, get that MRI scan seen twice and think about getting a CT scan because the MRI could be a sarcoma. And lastly, if the MRI shows that there is some issues with the signaling, then maybe keyhole surgery is not the answer. And maybe what you need to do is be careful and take that MRI and take that imaging result to, again, an MDT that deals with these complex issues. In this case, the MDT will need to be 2 MDTs, not only an MDT for the complex benign work that is carried out by the endometriosis specialist in the endometriosis center near you, but also a gynae-onc MDT, so a gynae-oncology MDT, just for an opinion. You don't really need to take it to the meeting. Take an opinion of the most senior person from the team.
Thank you. And what are the possible causes of endometriosis? Could it be inherited, and why?
So I'm so sorry for this answer. This is the answer that is written on the Endometriosis UK website. It is the answer that we've heard over and over again. And I wish, as a passionate carer for endometriosis sufferers, I do wish I knew the answer to this. But the truth is that the exact causes of endometriosis are not fully yet understood. But there are several theories that may contribute to the development of the conditions. And this includes immune system dysfunction, hormonal imbalances, genetic factors, and environmental toxins. For example, it is believed that certain environmental toxins, such as dioxins, may mimic the effects of estrogens in the body and contribute to the development of endometriosis. Remember, endometriosis is an estrogen-dependent disease. So there is good research to show that in countries that have a higher rate of xenoestrogens in the tap water, in the milk, it might be contributing to a higher rate of endometriosis in these countries, because endometriosis may not actually occur as 10% across the board. Research has also suggested that there may be a genetic component to endometriosis, as the condition tends to run in families. In fact, some studies have shown that women with a first-degree relative, such as a mother or a sister with endometriosis, are more likely to develop the condition themselves, which means that if you have a mother or a sister with endometriosis, just be that little bit more vigilant, just so that you know that if there is even an inkling of a symptom going on in a first-degree relative, that could be endo. And however, the specific genes that may be involved in the development of endometriosis are still being studied and not fully yet understood. Overall, endometriosis is a complex condition with multiple potential causes, and more research is needed to fully understand how it develops and how it can effectively be treated. Certainly, also in Manchester, they have a great research going on with regards to biomarkers and the prediction of endometriosis. Worryingly, there is a paper from Switzerland about a biomarker that they're now testing women for, actually, and the test is available for a significantly high amount of money with really poor research backing it. And you can also think of it as people who have a commercial interest in taking advantage of women who are suffering from a condition that is really common. And I feel that that's unfortunate because, as I said, I don't think we will ever have an answer.
Thank you, Zahid. Hopefully one day we will, but I know what you mean. Endometriosis UK really want there to be an answer. My next question is, are endometriosis and fibroids linked together as they are both part of the hormone imbalance?
I had a fair amount of think around this, as the beginning of the webinar, I did mention that, I really needed to go back to my books for some of these questions. But I think that endometriosis and fibroids are both conditions that can affect the womb and cause symptoms such as pain, heavy bleeding, and subfertility. However, they're not directly linked to each other as they have different underlying causes, I believe. And endometriosis is a condition that can cause pain, scarring, subfertility, amongst other symptoms. Uterine fibroids, on the other hand, are benign growths that can develop in the muscular wall of the uterus or in different layers of the uterus. The exact cause of fibroids is not known, but is thought to be related to hormonal imbalances, particularly with estrogen. Fibroids can cause heavy bleeding, pain, and pressure on the nearby organs, and amongst other symptoms. So the symptoms are very similar. However, whilst endometriosis and fibroids are thought to be influenced by hormonal changes, they can have different underlying causes and require different treatments. Endometriosis is often treated with medication, unfortunately, to control the symptoms and to control the progression of endometriosis, whilst fibroids may be treated with medication or surgery to remove the fibroids themselves. So it's worth noting that some women may experience both endometriosis and fibroids, as they are both relatively common conditions, and the two have not been found to have a correlation, but it is incredibly incredible that in 50% of patients with up to 50% of patients with fibroids, you can find endometriosis to some degree. And in certainly in a more recent paper, it was somewhere between 20 to 26%.
Thank you, Zahid. And can the existence of untreated endometriosis trigger the appearance of fibroids?
Trigger the appearance, or mimic the appearance, I suppose.
It says trigger the appearance, but maybe answer both. Maybe mimic the appearance, and if that person can clarify.
Yeah, I think yes, it can. As I've mentioned, the symptoms are incredibly similar, so it is very difficult to tell the two apart. My money is usually on the symptoms, and if the symptoms show that there is a significant amount of bleeding, I will have a lower index of suspicion to get imaging done really quickly, because I want to see if there are any fibroids there, if there is adenomyosis there. So in both of these cases, I think one of the take-home messages is that do not just leave the gynecologist's office or your GP's office without having been referred for an imaging modality such as an ultrasound scan or an MRI scan. And if you have extra pelvic symptoms, it should be an MRI scan.
Thank you. And if you're postmenopausal and on HRT and fibroids start growing, can endometriosis come back if you've had it pre-menopause?
So if a person has been diagnosed with endometriosis prior to menopause and is currently on HRT for menopausal symptoms, they may experience a recurrence of endometriosis if the condition was not surgically excised before the menopause. Whilst HRT can help alleviate menopausal symptoms by increasing the levels of estrogen and progesterone in the body, these hormones also can stimulate the growth of endometrial-like tissues. So if endometriosis lesions are present in the body, the increased hormone levels can cause these tissues to proliferate, that is, grow, and potentially cause pain, bleeding, and other symptoms that endometriosis causes, depending on where they are. So in addition to the potential for endometriosis recurrence, HRT can also affect the growth of uterine fibroids. And some studies have suggested that HRT may increase the risk of fibroid growth or recurrence in women who have previously been diagnosed with fibroids. However, the evidence is not clear, and the effects of HRT on fibroids may vary depending on the individual. So if a menopausal woman on HRT experiences abnormal bleeding, pain, or other symptoms, it is important for her to find a gynecologist to talk to. They may recommend further testing or treatment depending on the cause of the symptoms and provide appropriate management. Again, going back to the fact that imaging would be required.
Thank you. And if you've had a hysterectomy, will fibroids come back?
No. So fibroids are exclusively a uterine disease. So I think the answer is no. And there are certain situations where hysterectomy is not complete, or a supracervical hysterectomy has been done with some uterine tissue left behind, and there are case reports that say that the endometriosis, the fibroid came back. However, the answer to that question is no.
Thank you. And with tibolone instead of normal HRT, will fibroids still grow?
I think the answer is very similar to my previous answer. Tibolone is a hormone replacement therapy, as well, used to alleviate menopausal symptoms such as hot flushes, vaginal dryness, and particularly it has a great androgenic effect. So it's fantastic for women who have a low libido and who have low energy levels. So that is my HRT of choice for women who have low libido, low energy levels. It is not typically used to treat fibroids or endometriosis at all. But if you're postmenopausal and experiencing abnormal vaginal bleeding or other symptoms associated with fibroids, it's just important to speak to a gynecologist to determine what the cause is and get appropriate treatment. In some cases, fibroids may continue to grow or can cause symptoms after the menopause, and further evaluation may be needed. As for endometriosis, it is possible for the symptoms of the condition to return after menopause, even if you have especially if you have been taking HRT medication like tibolone in the past. This is because endometriosis is fueled by estrogen, which again can be produced in small amounts even after the menopause from peripheral sources such as body fat. And also, if you are taking HRT, such as tibolone, it can increase estrogen levels to a very small level, but it might actually affect that as well.
Thank you. And I'm going to make this my last question because I can see it's 8 now. So is hysterectomy often needed for large fibroids?
It genuinely depends on the symptoms, and it also depends on how you define large. So my definition of large is very large. It's because and so will the 110 or so advanced laparoscopic surgeons that are mentioned on the BSG website tell you the exact same thing. That they are very used to a challenging pelvis, and so they can do huge myomectomies, particularly in women under the age of 45, under the age of 40. They will be happy to do huge myomectomies laparoscopically and even now robotically. I think a hysterectomy is not always needed for a huge uterus, but certainly my personal surgical limit is 22-24 weeks. That's a huge uterus. That's well above the belly button. And once the uterus gets that large, we need to discuss carefully with the patient about what her fertility choices are and what her fertility desires are. It is a very sad situation because fibroids invariably lead to subfertility, and so does endometriosis as well, particularly when both of them occur together. That can incredibly raise the risk of this happening. So you have to be very careful with that conversation. It is not a conversation for an SHO. It's not a conversation for a registrar. It's a conversation for someone who can actually sit down and discuss, very sensitively a subject which might be very close to the patient's heart. So I think hysterectomy is not always the answer, and I always say hysterectomy is the very last answer. But if a patient wants a hysterectomy, has completed her family, I am more than happy to say yes. So I'm not someone who keeps a patient from the surgery that they want.